Okay, awesome. Thank you, guys. I am Daniella Giles. I am a physical therapist for about 20 years now. No, 15. And I have been working mainly in rehab, SCI settings for the first period. And then now I work for Ride Designs, and I do exclusively mainly custom molded seating and positioning. So for my disclosures, I do work for Ride Designs and currently receive compensation from them, and do have a little bit of bias towards that orthotic and prosthetic concept. So that is my disclosures. Objectives here are to list 3 risk factors relative to aging with a disability, describe 3 key interventions relative to the anterior pelvic tilt, and identify 2 contraindications for interventions related to this diagnosis presentation. A couple key terms and definitions that I will be using, just referencing standards and measurements from 2013. Obviously, our standards are frontal, sagittal, and transverse plane measures, and then also related to the X, Y, and Z axes. Just a note, obviously anatomical neutral in medical documents, it's in standing, feet forward, palms up, and then we have our seated reference position that's been adapted to our wheelchair users, and we will have our neutral position relative to seating, and so the hips and knees are bent to 90 and palms are down. And so we have sagittal, frontal, and transverse views. So there's a bony landmark attached to each segment to be able to measure. Relative angles are angles that are measured between 2 body segments, so relative to each other. And then you have absolute angles that are relative to the position against the axes. And obviously the absolute measures change with orientation. So we do have to measure and remeasure in the same orientation in space. So let's talk about a little bit about aging with ASI. There's been some great courses on that. There's a lot of information developing in this category. So just to review, folks are living long, beautiful lives, almost identical lifespans to their able-bodied peers. However, almost all patients with an SCI will develop some asymmetries at some point in their lifespan. And it is correlated with quality of life measures. So that's been well established. And the pressure injury risks do increase with time relative to the age, the amount of time sitting in a wheelchair, that risk is going to increase. And then there is an acceleration of the functional decline in individuals living with disabilities compared to the normal aging process of individuals not with disabilities. And again, all of this is related to quality of life and needs to be addressed so that we can have happy individuals. And early interventions, the earlier we intervene, the more lasting and meaningful the outcomes will be through the lifespan. And so I'm going to discuss the demographics and presentation of the current case study. Okay. That was not, I'm still in a minute, sorry. I'm so sorry. This is the wrong one. Give me 1 second. Can you give me 1 second here? Good thing you're recording all of this fabulousness. Okay, so this is the individual that I'm doing the case study on. Her name is Caitlin. She was born in 97. She was injured in 2000. So she was only 3 years old, and it was an MVA. She is a complete Asia AC5, very low tone. And she came to us at 16 years old. I met her at 16, and her main goals were back pain. Her complaints and goals that she wanted to address included a lot of back pain and fatigue over time. She literally told me, I want to be able to put things on my lap, and I feel like my lap is disappearing, and I want to be able to sit up straighter so that I can set things on my lap. So that was a goal of hers. She was kind of developing some early stage 1 and 2 pressure injuries, and then she was wanting to go out and socialize with her friends and her peers, and she couldn't do that in her power chair. So she wanted to adjust manual chair seating as well. So those were kind of some of the goals coming in. So we did a supine assessment. I'm going to do most of this with 90 degrees of hip flexion. And so I want to assess everything in that seated position. So I'm going to bring those hips up, and then I'm going to assess kind of how much the lumbar lordosis can be reduced with some overpressure and with the range and the positioning of the hips. So through this supine assessment, I will kind of determine my thigh to trunk ideal thigh to trunk angle, and where the lumbar lordosis will present once I have that position. So I'm going to check things in supine. Here's a quick little video of just the assessment process. So when we're doing our assessments, I encourage folks to not only assess how much flexibility they have towards neutral or towards the correction, but also how flexible things are in the path that we don't want them to go, or in the negative direction. So you'll see me kind of check both of those things. Oftentimes there's plenty of room to go in the wrong direction and not quite enough room to go the way we want them to. So I'm just going to do the pelvic obliquity and see how easy things are. And then I'm also going to check the rib cage and see if there's more flexibility in one direction than the other. And the same amount of pressure really results in a lot of movement here and not quite as much movement there. But she is hypotonic, and so she does have generally a lot of flexibility. Okay, so sagittal plane measures that are relative here. So we'll start with the absolute angles. Again, these are relative to the vertical and horizontal planes, axes. So the things that we would want to measure are a sagittal head angle. And I'm going to be totally honest, I made these numbers up. So I kind of guessed a little bit at what the angle would be, but we would obviously measure them very specifically. But this is, she's close to about 18 to 20 degrees on her sagittal head angle. And thigh to trunk, sagittal trunk angle, sorry, not thigh to trunk, but sagittal trunk is 30 degrees. That is a positive number because it's going behind her with the right hand rule. Then we're going to look at sagittal sternal angle. So this is from the upper notch to the lower notch relative to vertical. And then sagittal pelvic angle. So this is, again, the ASIS to PSIS line relative to horizontal. And the pelvic tilt, as it goes forward, it's going to be a negative angle. So she has about a negative 30-degree angle. And then the relative angles that are pertinent here is the thigh to trunk angle. So we'll be looking, we took a look at that. So her thigh to trunk is 100 degrees, and her thigh to pelvis is a much narrower angle or smaller angle at 85. Not discussing too much of this today, but be sure to check your frontal plane and sagittal plane deviations, because oftentimes the anterior pelvic tilt will have a combined pelvic obliquity or rotation involved. So we will take a peek at that. I'll talk a little bit about intervention. So determining orientation in space is the first step that we would need to look at. Call this the DOOT test. This is the Daniella's optimal orientation test. Previously was a TOOT test. Anybody know my mentor and supervisor, Tom Hetzel? This originally was the TOOT test. So it was Tom's optimal orientation test, but I stole it. And so I renamed it. And by attending this session, you guys have authority to rename it again. So you put your first initial in that first spot, and then this will be your test to determine optimal orientation. And this is how it goes. You're going to tilt the patient all the way back, whether it be in a manual chair. I'll just support them or lean them back onto a mat table and guard them for safety, or a power chair. We can obviously use the power functions. You're going to tilt all the way back. You're going to manually kind of position or have them reposition if they can do it independently, but you're going to position them ideally in the ideal alignment. And then you're going to place your hands just in front of and in back of their lumbar spine and pelvic region so that you can feel movement. And once you have that set up, then you're going to kind of slowly bring that orientation back up, and you're trying to feel for the place at which the pelvis starts to rock anteriorly again, okay? So we're going to tilt them all the way back, feel for movement, start to bring them back up, and decide what point in space do they lose that, or they start to increase the lumbar lordosis, when they start to tip anteriorly. And at which point the pelvis starts to move, you're just going to kind of stop and pause. So that tells you they need to be in that level of orientation in order to keep the lumbar and pelvic positioning in that spot. So once you've determined that orientation, early intervention, it may be very, very minor, or a minor change. And so we may just measure the distance that we have them tipped under the casters, or we would somehow measure that tilt angle. So the relative absolute angle, measure the orientation angle. All right. Once you document that, you're going to decide, is that an acceptable orientation for them to live their life? Okay. Early intervention, it might work out. Okay. Later intervention, that position is probably going to be still staring at the ceiling, and that position is not going to be very functional. So we're going to decide, is it an acceptable orientation or is it not? If it is not an acceptable orientation and we really need to be more forward, then we're going to come in and bring in some abdominal support. Okay. So if they need to be in any greater orientation and their pelvis starts to move, we have to then go in and capture them anteriorly. Grab a towel, grab a sheet, grab anything you can. You can use your hands and just manually give that overpressure and that support into the front. But you're going to just see how that response is and if they can be reduced. So I would add that abdominal support and test that out. And then whether it be custom molding or a manual chair configuration with the mat table, with your physical assessments on your mat table, and then with your determining of the orientation, we're going to try to simulate a system that is going to work okay. So build it, design it, figure it out, get your stuff, and just test. So just trial a few things. By the time things are, the spinal asymmetry is pretty pronounced or significant, most of the time we're looking at a custom mold. So she's in a custom mold here, but it doesn't necessarily have to be. This could be configured seating as well. So the interventions that we're going to apply is bringing that thigh upwards. Okay, so we're increasing the hip flexion to try to get that pelvis to roll backwards or limit that amount of anterior tilt. So I will raise the sagittal thigh angle up. This is going to, the exact angle is going to be dependent on your patient and what's going on. But for this one, it was about 15 degrees, so that when she lowers her chair all the way to neutral, she is still maintaining a sagittal thigh angle of 15 degrees at all times. And then this is a place where you could use maximal hip flexion, or maybe even beyond their true femoral acetabular hip flexion, to kind of try to recruit the next segment, which is the lumbar spine tilting backwards. So you really want to maximize that hip flexion that they have available. And you can you can build it into the seating surfaces, support surfaces. Second thing we're going to do is we are going to block the dreadful sliding back into the wheelchair. So we have to have some posterior support that is able to stop that sliding backwards. So any way you want to do that, simulate it and see how well it works. And then last but not least, if needed, we're going to add the anterior support. So this is just a picture of the ones that there's many different options on the market from different manufacturers, but we're going to pick one that's going to work. This is the Ride Designs model. Okay, so front support is the new back support. It's really helpful in these cases. So I'm going to play this quick video. I'm going to talk a little bit through the process. I'm at 1 minute or so. So this is her applying her abdominal support. The key thing I want you guys to watch in this video is what she does with her orientation relative to her abdominal support. So when she was not tight and she did not have the support providing support there, she was way back in her orientation, right? As she tightens that up and gives herself some support, she can come out of her tilt because she's now stable in that position. So this is a great reflection of the balance between the two. You're either going to have to be in a tipped orientation, or you're going to have abdominal support, and there's going to be a fine balance in between the two. And you're not going to be able to hear it, but at the end here, she smiles so big and she says, I can breathe now. So for her, it's a really helpful device. Okay. And then, sir, how much time do I have? Okay, great. Okay. Then we're going to proof the outcome. So again, my mentors have ingrained in me the posture and postural tendencies, and we're always going to look at rest as the primary goal. So we want them to rest into good alignment. Next, we're going to look at maintaining for fine motor tasks. And last but not least, we don't want to block any gross motor tasks. So you'll see her go through these 3 segments really quick. So I'm going to start the video and I'll kind of go as I'll describe as we go along. So again, she's going to first describe or position herself at rest. So we are going to try to get a restful alignment that is feels the best for her, where she can relax and breathe and rest. So she's going to adjust the tension on the belt accordingly so that she can to her desired support. So this is not something that I determine. It's going to be something that the user determines, and it's going to be something that may change with various functional tasks. So it's going to happen pretty quick here in a second. She's going to reposition, and then she's going to say, yeah, that's it. That's my comfortable spot. And the smile comes, and they say, whew, right there. That's what I want. And then we're going to move right into, so there's her yes. And then she's going to go right into fine motor and then into gross motor. So she has now gained the ability to drive. So that's the biggest concern with this is, can I get my full ability to steer the steering wheel, and can I reach and do my things? So what she does is she loosens up the straps and she pushes it kind of below her rib cage. Then she can lean over the top, that like you guys see, and that will give her the function. And here real quick, she's going to do her drive. Can I drive? Can I reach everything? Can I turn all my corners? And that was a yes. So she's also going to check some other gross motor tasks. Can I lean appropriately, get in and out? And then quickly she does if this is too tight and too restrictive, I cannot reach the door appropriately. And that is blah, don't like it. All right, so we're proofing our rest, fine motor, gross motor. Improve compliance by letting them feel it first. Okay. If you in 10 out of 10 people that you show an abdominal panel to are going to say, I don't want that thing. Okay. But if we can get them to feel the response and feel what their body can do and feel that response, then they're much more likely to accept it. They can apply and remove. They're fully empowered to do as you wish. Sometimes you might use it, sometimes you might not, and that's okay. Anything is better than nothing. There's going to be, I asked them to agree to a 2-week trial period, like just try it for 2 weeks. Give me your best buy-in that you're just going to try it. And after the 2 weeks, probably about 8 out of 10 people end up liking it, at least for one task or another. It may not be for all day. And then I also try to validate previously. People have tried to strap them in and it hasn't worked. So I validate prior failures. This is a funny one. She sent me, this is where I think I sit, and this is where I actually sit without my belt. So we got to also realize that sometimes people are going to assume different positions for different times of the day or functions, and it's not always going to be as pretty as we'd like it. Sleeping alignment is important, and so check that. Contraindications, please do not add shoulder harnesses or high chest straps, because that's going to facilitate or encourage the lumbar lordosis. You do not want to continue to add lumbar support. It's no longer in a weight-bearing plane, and you're filling in the space, but it's not an actual support surface, so you don't need to fill in. And then as they continue to scoot back, they're going to tell you that their seat depth is too long and they want you to shorten it up. But the more you shorten it up, the more they scoot back. So we have to stop the slide and not shorten the seat depth. And then some people like to sit up really, really straight, and they can have great posture, but then it can start tipping too far forward. So really watch those lower level paraplegic injuries who have some abs and really want to sit up tall and can then start tipping forward and be too straight. That often happens in my active veterans because they want to have that great posture they used to have. And then please, please, please intervene early and give supportive surfaces that are nice and stable and supportive for them. Summary you can read on your own. Everybody deserves a lap, and now she has a lap for her sister to sit on. Thank you very much.